Turn to our next speaker, Dr. Chad Christine, who's known to many of you. Dr. Christine is a professor of neurology here at UCSF. He was a resident here and he spent all his professional career here. He has a particular interest in Parkinson's disease, particularly in trying to identify biomarkers of the disease, trying to identify factors in individual patients that might predispose them to the disease or might affect the progression of the disease. And he's going to be talking to us today about maximizing current and developing future treatments for Parkinson's disease. Chad.
Thank you all for coming today. I really appreciate being able to share some of these ideas with you, and I want to thank Dr. Aminoff for making this annual event come to fruition, along with many of the other people in the UCSF Parkinson's Disease Research Center. So I'm going to touch base with quite a few of a number of things that are really applied to people with Parkinson's disease, medicines that you've heard about, and then we'll talk about new directions in Parkinson's disease treatments going forward. So if you've been here, if you were here last year, some of the first slides will be familiar, but I think they provide a basis or framework for which you can use to understand the other therapies that are going to be described later on. So the outline of the talk is as follows. We'll talk about an overview of Parkinson's disease and touch base with the current treatments that we have that are approved. We'll then talk about newly approved therapies in the past calendar year and an update on neuroprotection. And then we'll translate to treatments that are undergoing study in patients, and then touch base with one of my favorite topics, which is benefits of exercise in people with Parkinson's disease. And lastly, we'll talk about surgical treatments. One last thing is a number of the things that we'll be describing have to do with, we're actually done at UCSF with patients, and quite a few members in this room have participated in clinical studies at UCSF. So the asterisk is really for thanking people for participating in these studies and showing that we're actually quite involved in the process of discovering new therapies for Parkinson's disease. We all together. So Parkinson's disease is common. It affects 1% of those who are 65, and 1% of those who are 65, and 5% of those older than 85. So it's a common condition. It has major features that are what we call motor or movement related, and these can include tremor, slowness, stiffness, and as time goes on, often a gait or postural disturbance. And then a core feature that was appreciated about 50 years ago was that treatment with levodopa or dopamine agonists more recently can improve many of these symptoms or features. The condition has remarkable variability. No two people with Parkinson's disease are alike, even if they're in the same family. 25% of patients never develop tremor, and some patients with Parkinson's disease have a very slow progression with little change over 10 to 20 years. There's a lot of variability, and we don't understand that. There are classic autopsy findings that Dr. Forsyth just mentioned, and I'm just going to reiterate those a little bit furthermore here, but there's a loss of dopamine-releasing neurons. If you look at those sections of brain microscopically, you can see proteinaceous, you can see inclusion bodies, and if you have stains, which were developed in the last 15 years or so, you can see that the major protein component of these Lewy bodies is it's a protein called synuclein. And this is just touching base with an autopsy specimens of someone without Parkinson's disease, where you see a level of the brain called the substantia nigra. And in someone with Parkinson's disease, there's much less of this black substance or substantia nigra because there's been depletion of the nerve fiber layer. And this has consequences functionally if you do imaging studies to look at the normal uptake of dopamine in a normal person. You will see in at a level quite a bit higher than we just showed, the substantia nigra. This is called the putamen, to which the axons spread and reach towards. And this is where dopamine is actually released. And in a normal person, you can see a beautiful high signal of this tracer, fluorodopa, indicating that there's healthy axon terminals there that are ready to release dopamine throughout the day and with movement. But in Parkinson's disease, a similarly acquired image does not show that accumulation of the tracer, because there's been a loss of healthy axon terminals there. And over time, we've developed a number of treatments for Parkinson's disease, and I'm going to just broadly define them as levodopa-sparing treatments and levodopa-type treatments, for convenience. And the one of the current treatments is monoamine oxidase inhibitors. The two approved ones in the United States are selegiline and rasagiline. Both have a mild symptomatic benefit for patients with Parkinson's disease, and we'll also describe that both, because they reduce the breakdown of levodopa, can help with the treatment of patients undergoing levodopa treatment. So it can have a symptom treatment alone, and it can also help with people undergoing treatment with levodopa. The other levodopa-sparing treatment are dopamine agonists, and the current approved formulations in the United States include pramipexole, ropinirole, and rotigotine, a 24-hour patch. These days, pramipexole and ropinirole are available in slow-release forms. Amantadine, a drug originally developed for the treatment of the flu, has benefit for people with Parkinson's disease, particularly in the early state for tremor, and as time goes on, it can be useful for dyskinesias, which are involuntary rocking or twisting movements that some people have. And the last major class of treatment for Parkinson's disease is trihexyphenidyl, anticholinergics, of which trihexyphenidyl is one, and it can be useful for both tremor and for cramp-like symptoms that a number of people have. I'm now switching to the levodopa-type treatments that are available these days, and all levodopa treatments have a decarboxylase inhibitor, and the reason that is because if levodopa is given just alone, it is quickly converted into dopamine, and dopamine in the blood signals different parts of the body to make you feel ill or nauseated. So having a dual drug, levodopa and carbidopa, allows for the levodopa to not be broken down in the blood completely, and some of the levodopa makes it into the central nervous system. Levodopa is also available in slow-release forms, and that's been available for decades now. And these are called either ER, CR, LA, to designate it as such. There is a new, longer-acting form that I'll describe later. Entacapone is a different drug that was developed to help levodopa last longer in the blood. Instead of acting as a decarboxylase inhibitor, it is a catechol O-methyltransferase inhibitor, and it also, in combination with the decarboxylase inhibitors, reduces the breakdown of levodopa in the blood before the levodopa successfully makes it into the nervous system. Tolcapone came out around the same time as entacapone and is actually a little bit better in preventing the breakdown of levodopa in the blood through this enzyme pathway, but it has caused side effects in some, and so it's reserved for patients who don't get enough benefit from entacapone. Stalevo is the combination of levodopa, carbidopa, and entacapone, and is available in a number of preparations. So this here it seems to work. Okay, so this is another cartoon to show connections in the brain that are relevant in Parkinson's disease. The substantia nigra projecting its axons to the putamen here, and then there's also descending control from the cortex. And these groups of cells called nuclei are part of the basal ganglia and are involved in voluntary control of movement. This this cartoon up here is a blow up of this area in here and shows levodopa in the blood, and if it is not broken down by decarboxylases or by carbonyl O-methyltransferases, it can successfully pass into the brain. And there, levodopa can be taken up by dopamine-releasing axons into the synaptic space between the dopaminergic neuron and the medial spinal neuron. And this part here is now blown up here. You can see here that levodopa is taken up by the axon, and here it can be converted into dopamine, and then released onto the medium spinal neuron. So when a person with Parkinson's disease gets levodopa, it can be converted here and released normally. The other pathways involved in normal motor control are shown here, with the descending pathway of a corticospinal neuron which releases glutamate. This pathway can be modulated or improved by treatment with amantadine for people who have tremor or dyskinesias, and this is the site of action where amantadine works. This pathway where cholinergic fibers, or acetylcholine receptor releasing neurons, occur is right here, and anticholinergics can be used, such as trihexyphenidyl, to block involuntary coordination or to block abnormal release of this neurotransmitter that can cause cramping. So in Parkinson's disease, switch over here. In Parkinson's disease, there are common fluctuations that many patients will experience in the years having been diagnosed and been on treatment. And one is called wearing off, and one is called dyskinesias. Wearing off is a regular and predictable decline in the response that occurs several to many hours after a levodopa dose or a dopamine agonist dose. You don't expect medication to work indefinitely, and that's the phenomena that many people experience, particularly after being on these treatments for a number of years. It is the most common motor fluctuation, and it may not necessarily need any intervention or treatment if the amount of wearing off or the reduction in benefit is not severe. Peak dose dyskinesias are involuntary extra movements that are distinct from tremor and look like a fidgeting or wiggling movement, and can be rather subtle, that are only seen in certain circumstances, such as standing, washing dishes at the sink, for example, or shaving, or can be rather vigorous and strong. And these movements can be influenced by stress and can be quite noticeable at times. They're usually not as disabling as bradykinesia or slowness that many people experience, so that while it may be noticeable to others and look uncomfortable for many patients, they'd rather have a little bit of dyskinesias than a little bit of bradykinesia. And we think that, and actually we have a lot of information to show that these fluctuations have a relationship with blood levels of our medications. And this cartoon just shows this concept where if one is given a dose of levodopa, that level gradually rises to a point at which there's symptomatic improvement in the person. And that benefit lasts for a period of time, reflecting its breakdown in the blood. And then after a certain period of time, there's a reduction in that blood level or brain level, and then a person has wearing off. If a certain threshold is reached and superseded, then there may be these extra involuntary movements that we call dyskinesias. But there's a fairly good understanding of this phenomena, and a lot of the strategies that we're going to be talking about have to do with working to affect the blood levels of levodopa and to make them more constant. So first of all, recently approved medications. We don't every year get to talk about recently approved medications. They came in a flurry in January of this year. So I don't know which was the first one, since it seemed to occur on the same day in January, but one was a new form of carbidopa-levodopa called Rytary, and it comes in the form of capsules, and these capsules have two beads, one that releases levodopa in a standard or immediate release manner, and other beads that release levodopa in a more gradual manner. And the goal of this is to smooth out that fluctuation that you saw in this cartoon to one where there's a more sustained blood level. And a phase 3 study where there are randomized groups getting the new formulation showed about an hour of improvement on this new formulation of carbidopa-levodopa compared to the standard release forms. And so this, for people who don't have much off time, this kind of therapy may not be that useful. For those who do have lots of fluctuations and a lot of periods of time of the day when their medications aren't quite working, this might be a useful treatment. The other therapy that was approved this January is called Duodopa, and this is a more of a aggressive form of treatment because it's not a pill therapy, but it's an infusion therapy. And this is a cartoon missing the person. This is meant to be the abdominal wall right here, and some tubing going through the abdominal wall into the stomach with a bit of tube going into the upper small intestine, or the duodenum. And the idea here is to bypass the gastric area and to give a constant infusion of a gel that contains carbidopa-levodopa, and with the goal of providing people a much smoother levodopa concentration over the course of 16 hours during which it's on. This treatment's been available in Europe for some years now and offers quite a bit of stability with 2 hours or so of greater or of less off time, and therefore usually 2 hours of more on time for people undergoing this treatment. There's a bit of baggage connected with this therapy. You have a tube, it goes through your stomach wall, and you need to carry something that pumps the gel in. So this gel kind of Walkman-sized device needs to be carried with you or on your person, and the tube is clearly attached through. Because it's a device, because it's tubing, because it goes into your GI tract, there can be complications of the treatment whether the device or the tubing fail or need to be reinstalled, and that can cause some problems. But for a number of people, it's been useful, and it's available in the United States now. I'm now going to segue to neuroprotection, which is a big topic. It's something that is really a holy grail in helping people with progressive neurodegenerative conditions, but it's not an easy thing to find so far. These many strategies are being investigated, and so a very broad and even broadening approach or net is being applied to see what approaches might slow progression of Parkinson's disease. And we already heard Dr. Forsyth talk about something I won't talk about, ganglioside interventions, but dietary supplements have already been explored, a number of prescribed medicines have been explored, and growth factors, which you alluded to, are being explored. Large studies have been done and have been recently published. I alluded before to a study that we were involved in looking at creatine versus placebo. Another study not performed here, but at many other sites, looked at coenzyme Q10. Pramipexole did not slow disease progression, and a surgically implanted growth factor called Nerturin did not seem to show disease-slowing effects. The pioglitazone study was, actually there should be a star on that one too, because we were involved in that one. That did not show an effect either. But that, because the stakes are so high, we're all very interested in looking at different approaches, and ongoing in the United States and Canada is a study called STEADY. It's looking at an approved medication that was developed for high blood pressure and that in animal model seems to protect dopamine-releasing neurons. And that's a medication called isradipine. And so that study began, I believe, in November of last year and is filling to capacity right now. So that's a very rapid enrollment of 330 or so patients into this study, and we'll be eagerly awaiting the results of this study that's expected to last 3 years or so. Another study has just been funded by the NIH that is looking at a different approach or different agent. It has been observed that people who have gout are less likely to get Parkinson's disease, and people who have high urate, which is the way we help diagnose a person with gout, seem to have a slower progression of Parkinson's disease if they develop it. So urates has effects that seem to be antioxidant in nature, and with this biologic plausibility and these observations in a number of studies showing possible disease slowing, there's been interest in raising urate, not to the gouty level, but just a bit, and seeing if it might slow the progression of Parkinson's disease. So there is a study that is funded that will probably begin this next spring for people with early Parkinson's disease, and being observing these patients compared to a group that doesn't receive insulin to see whether there is a disease-slowing effect. Those are the big studies going on, but there are smaller studies that are being looked at, and they're outside of those biologic mechanisms. One is looking at a synthetic agonist for glucagon-like peptides. Glucagon is involved in sugar. It's a sugar hormone type hormone, and it's sort of the opposite of insulin. And there was a single center randomized study that showed benefit at 12 months. And so when there is a signal or an observation of possible benefit, these studies will be funded usually to a phase 2 study where some people get it and some people don't. Another agent that has really been talked about for 15, 20 years now is glutathione, and it is a native antioxidant that's contained in all cells. And because there's been concerns about the amount of, there are concerns that the dopaminergic part of the pathway of cell death in Parkinson's disease is due to poor antioxidant control in the cells. This has been something that's been talked about a long time. The problem with pills for glutathione and for intravenous infusions is that glutathione is broken down by the liver very rapidly. So something you give into the blood is unlikely to get into the brain. So this study is looking at an intranasal preparation with the idea that it will come more directly into the central nervous system. I'm glad that Dr. Amanoff and Dr. Forse have talked a bit about prion hypotheses and protein aggregation, so that we've at least introduced this concept. I'll try to do it a little bit with a cartoon here. The concept in prions is that there are normal proteins, and proteins are not just a sequence of amino acids, but they have a complex structure, and that structure is important to their function, to their normal function. If proteins become shaped, misformed, they may not work as well and they may tend to clump. And that's the idea here that, that normal proteins, whether it's prion or alpha-synuclein, can develop a shape that can be a form that other synuclein or other proteins take on as well. And so, sort of like folding a folded chair, one folded chair, if it's in a certain conformation, might help. If you lean another chair against it, it might also fold and form into that manner. So the idea is that normal proteins produced by healthy cells may have random or triggered misfolding events, and once you have a number of these misfolded events, this can trigger an ongoing misformation of native proteins, and this can develop into a protein aggregation. This probably is happening in everybody's brains and bodies all the time, and we have a normal vacuum cleaner system that sucks up these misfolded proteins. But if it gets beyond a certain level, like a teenager's room, it could be catastrophic. So this is an idea that applies to prion disease, and people are wondering whether it has aspects, not every component being the same, but aspects that apply to neurodegenerative conditions in general. And the idea provides a possible treatment intervention, because if you can develop a therapy that can recognize one of these misformed proteins and leave the normal proteins alone, then you might be able to interfere with the process, sort of like a visiting housekeeper who can get into the teenager's room intermittently to scoop up a critical mass so that the room is still usable. So that's the idea here, and I think you don't have to buy in completely for it to be a possible useful concept here. So this is an idea that's being approached in Parkinson's disease as well as Alzheimer's disease. And there are two real trials going on in patients with Parkinson's disease, and one is the traditional vaccine treatment, where you're given a vaccine, the vaccine teaches your immune system to recognize the abnormally shaped protein, and then hopefully just remove that at a level that's not disruptive to the rest of the nervous system. And so a vaccination study has been conducted in Austria with 24 subjects at 2 different doses, and it's been safe so far, and at least 50% have developed antibodies to the synuclein protein that's abnormal, and in both serum and spinal fluid. And there's more going on since this has started, but it's quite interesting. And that's we think would be a one-time treatment, or maybe a one-time treatment with boosters, kind of like what you get with the flu or other things. But this concerns some people, because what if the immune process revs up too high and you can't control it? And this actually did happen in Alzheimer's disease studies some 10 or 15 years ago, where amyloid antibody or vaccinations were done. They worked terrifically well in experimental animals, but in people, some developed some encephalitis, and so that provided a lot of caution to the pharmaceutical community to slow down here. So the more cautious approach is to not give a vaccine, but to give an infusion of antibodies that you can control or you can turn off at some intervals, and you can look as to whether there's a slowing of the disease process. And that's what they call passive immunization. It's not being just used in Parkinson's disease, but it's being used in other neurodegenerative conditions as well. And so at least one, and I think several, are ongoing in passive immunization therapies. Okay, it's been in the press, 2 weeks of it now, and what are we talking about here? So this is the nilotinib. There's a big neuroscience conference that occurs annually around this time of the year, about a week and a half ago. And there was a release of information about a phase 1 study looking at the safety of this chemotherapy agent, nilotinib, or Tasigna, as to whether it is safe in people with advanced Parkinsonism and whether there's a hint of benefit. And so this agent is known, was developed for leukemia. It's useful for certain kinds of leukemia, and its proposed mechanism is to improve the lysosome function. And the lysosomes is this compartment of the cell that helps digest misfolded aged proteins and get rid of it so it doesn't, so prion-type phenomena don't occur, and there's enough room in the cell for the normal cellular activities to occur. So the idea was we're going to get better house cleaning going on for aberrant proteins with when this drug is applied. And so I think that's the overall idea of the study. And so they brought in 12 patients with really advanced Parkinsonism, including Lewy body dementia and Parkinson's disease patients, and they received about a 10% dose of what is usually used in chemotherapy. One patient dropped out, don't know why. We really don't have much information about this study, and everyone's really got to know that, because I think a lot of us have received numerous inquiries about availability, when it's going to be dosed to them, and all that kind of stuff, and we really don't know much about this at all. But one patient dropped out for reasons we don't know. We know that the authors say that were cognitive and mobility improvements occurred in 10 of the 12 people in it, and that when patients were stopped on the treatment, the benefits stopped. Now, I don't think I need to tell you, but if the analogy runs true, that just cleaning up someone's room shouldn't make them an A student. It just doesn't work that way. And so many of us in the scientific community or working with patients with Parkinson's disease don't really understand that if the function is at the level of cleaning up cells just a little bit, how could there be so much improvement? And so there's a lot of concern or skepticism that maybe what's involved here is a very strong placebo effect, or maybe an effect that's well outside this idea of it being a lysosome function enhancer. So the strong benefits don't quite square with this phenomenon at all. So I think all of us are very interested in the results. We all think that it should be followed up in future studies, but we can't be writing prescriptions for something that's a chemotherapeutic that could be dangerous in people who really are functioning quite well. So we're going to be very interested in the phase 2 studies that will be going forward, but it's not ready for prime time. So now I'm transitioning to other treatments being involved and evaluated from, instead of the neuroprotective angle, these are agents that are more in the traditional realm of Parkinson's disease treatments. And one is a new possible monoamine oxidase inhibitor. We already told you that the monoamine oxidase inhibitors raise dopamine at the synapse by reducing its breakdown. Not only in the blood do the monoamine inhibitors prevent breakdown of levodopa, but in the brain they reduce the breakdown of dopamine. And so adding a monoamine oxidase inhibitor to someone with dose response fluctuations on levodopa can improve on time by up to an hour a day. Safinamide is a new monoamine oxidase inhibitor that also has an action of blocking sodium channels and glutamate release, and it's thought that this agent might be less likely to cause dyskinesias than the other two monoamine oxidase inhibitors, and that was seen in one study. We'll have to see if future studies bear this out, and if so, it may be a new agent on the market in the future. Other targets, non-traditional targets, are also being looked at. And one of these is the adenosine A2 receptors. Adenosine receptors are in the basal ganglia, we know, and a study done here, actually 2 studies done here, have looked at 2 of these adenosine A2As. There seemed to be benefit in both of these studies. One is actually approved in Japan and is undergoing FDA evaluation here, and another of those is undergoing a large phase 3 study. But just so you get to take home something practical, caffeine has shown benefit in a small study, and a larger is planned for motor symptoms. So just a bit of coffee a day or tea or something else can help with overall motor control, at least in a small study. We mentioned amantadine before. It is a kind of a tricky medication to use. 1 pill a day doesn't seem to do anything. 2 pills a day seems to do something, but it's often necessary to give 3 pills a day, or 300 milligrams. But between 200 and 300 milligrams a day, some people develop toxicities and hallucinations or other problems. And that has led other people to cut pills in half or to use syrups to kind of micro-dose this medication. And one pharmaceutical company has tried to address this with a longer-acting version of amantadine, and this has been in their clinical studies showing some benefit in dyskinesias. Another agent outside of the traditional class is a selective partial serotonin agonist, and this showed in a small study that was blinded though, reduced dyskinesias. Again, caffeine, very practical. A secondary analysis of a larger study looking at pramipexole and levodopa showed that self-reported caffeine consumption greater than 12 ounces, for those who want details, greater than 12 ounces was associated with less frequent dyskinesias. So if you don't have dyskinesias, you don't have to be listening to this right now. But if you do, you may want to have 12 ounces or more a day if they're bothersome to you. New treatments for wearing off. So we've talked about this in the past, and people keep asking me, where is the levodopa patch? Why am I enslaved with pills, and I don't want a tube in my tummy? What about a levodopa patch? It has gone to a phase 2 study with benefit, but we're not beyond that right now. Hopefully there will be a phase 3 study, and that's the launching point to a treatment being commercially available. For rescue of off-state, people are looking at a new way of delivering levodopa, and that's an inhaled version that's gotten to phase 2. And then thinking about improvements in already approved classes of medications, we've got entacapone and tolcapone, and then there's this new one, opicapone, which is a new inhibitor that's shown some benefit. Okay, you never get to hear talk from me without some evidence for the benefits of exercise. A recent study looked at 230 and randomized half to exercise group and another half to a more normal group. The exercises were 40 to 60 minutes 3 times a week, which most of us could indulge ourselves towards. And the exercise group scored better on physical battery, standing tests, fear of falling, and quality of life. And in those who had the less significant, less severe Parkinsonism, there was a reduction of about 80% in the number of falls. So you won't have a reason for not exercising from me today. There are other approaches to Parkinson's disease treatment, including gene therapies. I won't talk about them today. We are actively recruiting for one of these studies, and I will just jump to the conclusions here, which is that we've had 2 newcomers to Parkinson's disease treatments. Drug development for new treatments is established, and is established in new classes. There are refinements in old drug classes, and new treatments are being approached. A wide variety of neuroprotective studies have been looked at, and have been negative so far, but new ideas are coming to clinical trials now. Exercise still is useful for patients with Parkinson's disease, and for more advanced conditions, neurosurgical approaches to deliver either stem cells or gene therapies are being looked at right now in the United States. Thank you very much.
Chad, that was a great talk. Thank you very much. You covered an enormous amount of ground. I hope he showed you that there are a number of promising agents coming up, both agents that might protect from the disease as well as agents to treat the symptoms of the disease. And so we really are entering an exciting time. Chad, again, thank you.